Susan, let's start with you because I think you're such a hero to so many women who read your cover story in the New York Times Magazine. Gosh, I guess a couple of months ago. And I've even had friends who've asked me about it as recently as this morning because they're now just getting around to reading it or someone sent it to them. What was your reaction to the reaction?
I have to say I was stunned. I mean, of course, the reason we did the article was to address this gap that seemed so apparent just based on the conversations I was having with a fairly wide circle of friends. I mean, most of my women friends now are in their early 50s. And, I'm not a shy person. I ask a lot of questions of my friends. And
You're a reporter.
I'm a reporter. And it was amazing to me the range of the range of confusion and how common it was. So we knew that there was a total need for some kind of information. And at the same time, I would say within an hour of it going up, I had one friend text me and said that she had already had the article texted to her on 4 different girlfriend group threads that she was on. And it had just gone up. And that was what we started hearing over and over and over again, that every woman who was in some big group text thread, I clearly am not in enough of those, but they were getting them from all sides, and it was just circulating, and the comments started pouring in. And on the one hand, as I said, it seemed sort of like, yes, of course, that people would be relieved and surprised to see all this information in one place in the New York Times because there had been such a hunger and confusion about it. And on the other hand, you never expect that kind of reaction. You just can't.
Becky, Dr. Brightman, full disclosure, is my doctor who has said I could call her Becky.
Absolutely.
During this podcast. You were doing backflips when you read this article. I think you and I talked about it. You were talking about it with your fellow OBGYNs. What was your reaction?
I was so excited. I know I met Susan at last fall's NAMS meeting.
Well, explain what NAMS is.
North American Menopause Society meeting in Atlanta. I knew she was working on the article, and the morning, I think it came out initially online, and then it subsequently was in print a couple days later. I woke up and I had already received several emails with the link from friends. When I called into the office, several patients had called. By the time I got into the office, I had, gone through the article, and then I subsequently listened to it several times. As a matter of fact, one of my very tech-savvy friends sent me a picture of the cover story with a QR link, which we actually have in our waiting room for people to read. And then I text the link to several of my friends, patients. It is the greatest article. It is so affirming to what I do. I feel it is such an uphill battle trying to discuss some of the things we're going to talk about now and to explain to people and reassure them that what their experience is normal, but it's part of the menopause transition, and women need to be heard. And I think it was the most validating article. And it also really went to discussion of the statistics and why menopause hasn't received enough attention and why hormones have received such a bad rap.
We're going to talk about the bigger picture about women's health in general in a little while. But first, I want to really do a deep dive into the article, Susan. How did this piece heard around the world come about? Was it because you were going through this, your friends were going through it, and you all were confused?
I actually really am glad you asked that because the reason this article came into being is really due to the vision of my male editor-in-chief, Jake Silverstein.
Wow.
That's
I know.
Amazing. I'm impressed.
Stop the presses.
I know. And
Was it his wife?
I'm not sure I should say more, but he came to me and said, I think we should, and my wonderful editor, Elena Silverman, as well, said, I think we should do an article about menopause, but it was a very big, baggy topic. I didn't know where to begin. And I started looking into it. And I will confess that I went away with my college friends for a late, COVID-delayed 50th big birthday getaway. And I said to them, and they were all going through it, and they were all having horrible experience. Not all of them, but there were many, many horrible experiences, much bemoaning of the lack of information. And I said, they want me to write a big story about menopause, but I'm not sure. I don't know. It's kind of like, is that what I want to be associated with professionally?
Seriously?
Well, and they were like, you're crazy. Like, if there's a stigma, then like you have to be part of removing it. And so I thought, okay, they're right. But at the same time, you don't actually think that it actually might go that far towards removing some of the stigma of talking about it. But I have to say that in a lot of the comments, people did say, I feel liberated to talk about it now. And my mother never spoke to me about it. And thank you. I feel seen. There was a lot of that kind of conversation happening.
I know that you use your friend group as an example of some of the experiences women have going through menopause. And your writing is pretty vivid, Susan. I wondered if I could just quickly read this paragraph. For the past 2 or 3 years, many of my friends, women mostly in their early 50s, have found themselves in an unexpected state of suffering. The symptoms they've experienced were varied and intrusive. Some lost hours of sleep every night, disruptions that chipped away at their mood, their energy, the vast resources of goodwill that it takes to parent and to partner. One friend endured week-long stretches of menstrual bleeding so heavy that she had to miss work. Another friend was plagued by as many as 10 hot flashes a day. A third was so troubled by her flights of anger, their intensity new to her, that she sat her 12-year-old son down to explain that she was not feeling right, that there was this thing called menopause, and that she was going through it. Another felt a pervasive dryness in her skin, her nails, her throat, even her eyes, as if she were slowly calcifying. By the way, you're a really great writer, Susan. I just want to say that.
I have really verbal friends, too. Their quotes are all great.
It's so evocative. Becky, well, before I talk to Becky, Susan, the more you looked into this, were you surprised at how significantly menopause was affecting women in their daily lives?
Well, you start to hear about it first from your older friends. I remember riding the train with a friend of mine who was 10 years older, and and I have another friend as well, and they both just talked a lot about how disrupted their sleep was. One friend of mine said at least she was an incredibly well-read, up-to-date reader now, because she was always up at 2 a.m. reading for hours. And I just thought, these women are heroes. How are they functioning? Life is hard enough. What is it going to be like when I'm not sleeping at night? So I was already thinking about it a little bit. But when I got together with my college friends, that was when we really, on this getaway, in Maine, was when I really started hearing about how drastic it had been. And so it was interesting is also the range of reactions that my women friends had. I would say that some of my friends were looking for answers and somehow could not find them or did not know what information to trust. And then there was a whole other cohort of friends who I think just thought, this is just my lot in life, to suffer. Like, this is what happens when you get older. And I think they thought, well, if there was something that could be done, surely somebody would have said something about it.
And Dr. Brightman, Becky, you see patients all the time. Do these symptoms sound about right to you?
Absolutely. And it's interesting. When I practiced obstetrics, I used to say, well, hormones of pregnancy, which are the hormones that change during menopause, affect every organ system in the body. And the same is true with menopause. So it's not just night sweats and hot flashes. And honestly, it is really the disrupted sleep and the night sweats initially in one's 40s that sort of precipitate mood changes and difficulty focusing and, cognitive changes and all the things women talk about.
You didn't mention brain fog, and I'm glad you mentioned cognitive changes because in this paragraph anyway, but you do later, Susan, when you're at a cocktail party and you see an older writer. This actually broke my heart, honestly. Tell us about that conversation you had, which you include in your piece.
There was a writer whose work I had always admired, and she had precipitously retired. And
how old was she?
I'm going to guess, I'd have to work backwards. Maybe mid-50s, mid-50s, late 50s. And I'd always wondered what happened, and I saw her at a party, and I really didn't know her very well at all. And I just said, I just loved your writing so much. I always wondered, why did you stop? And without even hesitating, she just said, menopause. I couldn't find the words. And she is sure it was that was the cause. It wasn't, as if she was on the path of dementia. It was just completely timed to this phase in her life. And it was really agony for her, I think. And I think that always stuck in my mind as well. As a writer, it sent a chill down my spine at the time. I remember thinking, am I going to become one of those writers who suddenly becomes a sculptor in her 50s,
Right.
So maybe I was on the alert for it. But, that is an extreme case, I would say. But there are extreme cases. And I think, by the way, when I later spoke to her about it, she did say that she thinks she went into menopause right around the same time as the WHI, and that was why it was something that wasn't even discussed for her.
We're going to talk about the WHY in a moment, but first I just want to ask you about brain fog, Becky. I mean, do doctors know what causes this and how it's associated with menopause?
So as hormone levels start to fluctuate, there are super high levels of estrogen and super low levels, and it's the highs, it's the lows, it's really the disruptive sleep. And the fact that women can't focus and feel foggy, they're looking for words. And for many women, and there have been studies that show that many women will return to baseline with respect to word finding and cognitive function. For some women, there will be some age-related decline, but it's very, very scary when it happens to you. And I think that for so many times, and I think that Susan's article is so eye-opening for women, because as doctors, those of us who practice menopausal medicine, we know this, but for many women it'll be eye-opening because it can be one of the earlier signs. Someone can be having regular menstrual periods, but start to notice, gosh, they're not sleeping, they're drenched at night, they're exhausted during the day, they can't make it through work. And I think now that we have so many women in the workforce, so many women, we have very, set the bar for ourselves. It's a very high bar, and we want to keep achieving. And one wants to be their best self. And it's very hard when you've been so impacted by the, inability to sleep, brain fog, and the transitional phase that just, people say, well, it's not me. It's not me. I've never been like this before. Why?
Parenthetically, I started doing the patch, a hormone patch, when I think I went through menopause at around 54 because I was anchoring the CBS Evening News and I didn't want to have like a brain fart in the middle of the evening news or forget the question I was supposed to be asking a correspondent.
Absolutely. Well, WHI or not, I will say post-WHI, my patients who came in begging for hormones were those women who were high-achieving, hardworking women who needed to, present, be on stage, and really understood the toll that hormones or the lack thereof, were taking on their lives. So it was interesting.
We're going to
not alone.
Yeah, we're going to get into the Women's Health Initiative and the hormone study in a moment, but I think you raised this, Susan, in your piece, and you do wonder if men were going through this experience, if we wouldn't have a lot more solutions. In fact, you write, imagine that some significant portion of the male population started regularly waking in the middle of the night drenched in sweat, a problem that endured for several years. Imagine that those men stumbled to work exhausted, their morale low, frequently tearing off their jackets or hoodies during meetings and excusing themselves to gulp for air by a window. Imagine that many of them suddenly found sex to be painful, that they were newly prone to urinary tract infections, with their penises becoming dry and irritable, even showing signs of what their doctors call atrophy. Atrophy or atrophy?
Atrophy.
Atrophy. Imagine that many of their doctors had received little to no training on how to manage those symptoms, and when the subject arose, sometimes reassured their patients that this process was natural, as if that should be consolation enough. That was such a funny paragraph, too, because I've said lately when I've been talking about women's health issues, if we had focused as much attention on these issues as we had on the development of Viagra, imagine where we'd be.
You have to think, and it does have to, you can't help but think that it is about a discomfort with not just female sexuality, but aging women's sexuality. It's just not seen as a priority.
We're going to tease out some of the things you mentioned, but one is the discomfort doctors feel. I can say from personal experience that Becky Brightman is an excellent doctor who talks to her patients about pretty much everything, including menopause and a whole host of issues. We don't have to get into detail here. But, Susan, you found out in your reporting this just isn't the case.
I think it is pretty unusual. and you can talk about the different kinds of doctors who see women. Some women stop seeing gynecologists and they only go to family medicine or internists. And those doctors obviously, need to be well-versed in so many topics, but they really are underinformed, I do believe, about menopausal symptoms and about hormone therapy in particular. I do think that many OBGYNs, if a woman comes in and she is absolutely gutted by symptoms and is, it's completely disrupting her life, I think increasingly their people are moving away from the older fears, and they do recommend menopausal hormone therapy. But if it's not that extreme, I think it's easier just to move on because it is a kind of complicated conversation. People do want to understand what the risks are. They are kind of individualized. It's hard to explain the history. It's hard to overcome people's hurdles. It's just time-consuming. And, in the defense of many OBGYNs now, they have 15 minutes. They have other things they have to get through. And unless the person is completely wiped out and useless and, in a state of extreme suffering, it might just be easier to move on. I mean, that's sort of the impression I get.
I mean, that's so sad. This is 2023. I don't mean to dump on doctors, but so many, it seems, are doing a disservice to their patients. And by the way, who created this? I know managed care, but this 15-minute window.
But it's managed care, and I feel like I'm in a very fortunate position where I've created this practice where I can spend as much time as I need with my patients and take the time because,
you also
as I
don't
say,
take insurance.
Well, exactly, and I wouldn't be able to. I wouldn't be able to have this kind of discussion or practice medicine the way I want to, and I feel very lucky. And I think a lot of it has to do with being in New York and everything else, and I'm very, very aware of that. But the problem is, again, you have 15 minutes to spend with the patient. It's a very long discussion, and it's not a one-size-fits-all when it comes to deciding whether or not menopausal hormone therapy is for you. There are many different types of menopausal hormone therapy, and there's certain tests that I need to make sure someone's had. We have to go through family history. You can't do that in 15 minutes. So it's tough, and I also think doctors don't necessarily, want to take the time. They don't find it really interesting. And again, it's opening up a can of worms.
When one of your friends, Susan, expressed concerns about a lower libido and vaginal dryness, she could tell her doctor was uncomfortable talking about both. You write about this. And you quote her as saying, "I thought, hey, aren't you a vagina doctor? I use that thing for sex."
Yes, but I think sex also is a complicated subject. It has to do with emotional relationships and is anybody on an antidepressant and how's your marriage? I mean, I think doctors must feel it opens up a huge can of worms that if you open it, it'll never stop. So I certainly I think that it's not something that in general gynecologists are excited to talk about.
That quote made me laugh out loud.
It was a great quote.
Let's talk now about the Women's Health Initiative. So, Susan, there was a 1991 National Institutes of Health hormone trial. It was the first clinical trial involving all women, thanks to Bernadine Healy. May she rest in peace. I always feel like she doesn't get enough credit. The NIH director who started the WHI. So let's start by talking about what that trial was designed to do.
So it was the largest all-women trial, as you say, and it was trying to answer a couple of different questions. But I would say the question that drove its initiation in the first place was, are hormones, in fact, good for women's health, specifically cardiovascular health? And there was a concern that there might be some elevated risk of breast cancer, but there had been a lot of observational studies that suggested that when women went on hormones, they saw lower rates of cardiovascular disease.
Because we should mention they do have lower rates until they go through menopause, and then their rate of cardiovascular disease equals men, correct? So they were thinking estrogen had some kind of protective quality for the heart.
That's exactly right. And in fact, one of my favorite quotes in the piece came from a doctor, Hadeen Joffrey, who said, "You don't understand. I had a slide that said we should have estrogen in the water. It should be like fluoride." That's how good for women people thought that estrogen was.
But there was some concerns about estrogen, I guess, Dr. Brightman, where maybe this breast cancer question was kind of looming large.
Right. So the WHI was designed as a prevention trial to see whether or not hormones actually prevented disease. What happened with breast cancer? Did it prevent coronary artery disease, cardiovascular disease? Did it help bones? And then it was abruptly halted as we know, because there was a signal that perhaps it did increase the risk of breast cancer. And that really has to be teased apart.
Before we talk about it getting halted, I read that, I think in your article, Susan, which is, my main source for everything hormone, is that estrogen had been approved by the FDA like in 1943, right, for certain things. And it had been around for decades, right? And women were getting a lot of positive results from it, Becky?
No, so what happened is it was finally realized that, women were using just estrogen alone. And then it became apparent, I think, in the 70s that women really, that estrogen would stimulate the lining of the uterus. So in order to keep, and when you have too much stimulation of the uterine lining, women are at increased risk of getting endometrial cancer of the uterine lining. So by the addition of progestogen, progesterone being one of them, you can, regulate and you can mitigate the increased risk. So in women with the uterus who were going to use menopausal hormone therapy, they needed, if they were taking estrogen, they had to use some sort of progestin. And for women without a uterus, they could just be on estrogen alone.
So this was the first big study to determine, like, scientifically, what are the pros and cons of hormone replacement therapy,
exactly.
pretty much, right?
Let's get an answer to this. And by the way, Patricia Schroeder, may she rest in peace, also was one of the people advocating for this research.
I read that, and I love Pat Schroeder,
Me
too. And I feel like she didn't get enough attention when she passed away.
Yeah.
What do Pat Schroeder and Bernadine Healy have in common? Never mind. All right, so suddenly, as Becky intimated, Susan... That was a TV show, by the way. The trial.
I watched it.
The trial was stopped. Why?
It was stopped after 5 years because they found in the group that was taking both estrogen and progestin, which is to say women who have uteruses, that they were seeing an increased risk of breast cancer. That's the point at which it reached a threshold that they had decided.
5 years? I thought it was longer, no?
No, it's just about 5
years.
years.
1996.
Mm-hmm. Yeah.
For women on the
wait.
Yeah, how did this work?
It was 2002.
It was
crazy?
2002.
The study was started
Okay,
in
sorry,
91.
pick up there.
I'm sorry. The study was started in the 90s, but, they were recruiting people, and I think it was stopped because there were other people who had used it at 5 years. And I think they used a 5-year benchmark, at which point I think certain people had been on it 5 years to just stop because clearly there was what they perceived as an uptick in breast cancer in the group of women using estrogen plus a progestogen.
Even with the progesterone or progestogen?
No, in that group, there was an uptick in breast cancer. But they continued the study, and they did not see it in the group of women using estrogen alone. And it's so interesting because estrogen is what gets the bad rap. But in the estrogen group that, again, estrogen alone, no increased risk.
So it got changed midstream.
They didn't. It was supposed to last for 8.5 years, and the idea that they halted it unexpectedly after 5 years was very big news. They also held a very big press conference, and when people understand that a study has been stopped unexpectedly, I think they think that translates into, and therefore you too must stop using this medication.
Well, you write. I remember covering this back in the day, by the way, and you write. What happened next was an exercise in poor communication that would have profound repercussions for decades to come. What did happen?
Basically, representatives of the WHI, very well intended, but not particularly media trained, went on television shows and started, engaging in conversations in which a lot of statistics were rattled off. And some of those statistics sounded very, very scary, such as 26% increased risk of breast cancer. And if you hear that number and you're not particularly statistically literate, which, let's face it, most of us are not, I think that can mean a lot of things. I think you might think, does that mean that there's a 26% chance that I'm going to get breast cancer? Or, what 26% increased of what is really the question. So what people, I think, couldn't do the math in their head was if you have a very, very low baseline risk of breast cancer, which is true for most women between 50 and 60, like it's 2% and change, then of course, a 26% increased risk on top of that, you're still under 3%. It's a very small increase. But that's not how the numbers were presented to women.
Right. In fact, the coverage was pretty breathless and I would say in retrospect, unintentionally alarmist. you talk about an interview that Ann Curry did on the Today Show. And I was working on the Today Show back then, and I kind of remember all of this pretty well. And Ann asked what made it ethically impossible to continue the study, and one of the chief investigators for the WHI said, well, in the interest of safety, we found there was an excess risk of breast cancer. And then Ann did rattle off some numbers, and it said you increased your risk of heart disease by 29%, strokes by 41%, blood clots, and also invasive breast cancer by what you mentioned, Susan, 26%. So how did these numbers get so misunderstood or misreported?
Well, they were definitely not misreported. They were accurate. Those numbers were accurate per the WHI. I just think, again, it takes a little bit more time to say, okay, so what does that actually translate into for the average woman?
And what did it translate into? Because I know you did this in your piece. And
well, the math that we did was that if a woman's risk of having breast cancer between the ages of 50 and 60 is around 2.33%, let's say if you increase that risk by 26%, that means now you've elevated it to a 2.94%. So, that in the grand scheme of things, everybody can have their own comfort level with a 2.94% risk and how much you've increased it. But that's not, I don't think, how women heard it at the time.
And in fact, you say smoking, by contrast, increases cancer risk by 2,600%.
That's a risk.
So we're talking about a tenth, just a very, very small uptick if you're on HRT. What was the impact of all that coverage, Becky? You've been living it for the last 30 years.
Living it and continue to live it. It was unbelievable. From the second I walked into the office, the phones were ringing like crazy. Women were sent. I heard of stories where women were sent letters by their gynecologist at the time being told to stop hormones. I will tell you that my patients who, if I ever mentioned it, they were symptomatic, they were like, absolutely no. Don't I know that they could get cancer? It's amazing. And I still face women who say this to me all the time. But it was quite remarkable. It really was something else.
There have been other long-term ramifications. Medical students who graduated around this time, and you point this out as well, Susan, were thinking HRT bad. And that carried on throughout the decades they've been practicing medicine, right?
That is exactly right. I mean, I think the statistic we quote in there is that something like half of practicing OBGYNs graduated from medical school or finished their residencies after the WHI. So that's, a huge percent of the population who basically never really learned about hormone therapy in medical school. And also, I gather, in clinics, it doesn't come up very often, in part because of the population that's being treated. So there's not a lot of opportunity to learn it on the ground either.
The study was flawed in a whole host of ways, it seems. Can you all talk about why this study really wasn't accurate?
The most important thing is for women to realize that, I think women take this information, they say, how does it affect me? Well, the truth of the matter is the average age of the women in the study was between 62 and 63. Many of these women, did have some comorbidities. Many of them, on average, were 12 years beyond their final period, and the majority of these women didn't even have menopausal symptoms. So it was a lousy population to study. What we really needed to go back and do is look at the 50 to 60-year-olds. How did they do? And you know what? They did pretty well. And then once things are teased apart and we look at it decade by decade, it's very, very different. But essentially, one just extrapolated all the findings to themselves and thought, oh, no, I'm going to get breast cancer, I'm going to get heart disease, and my bones may be good, but that's about it.
Why did they use women in their 60s, or why was that the average age if most women, I'm assuming, go through menopause in their 50s?
I think there's two reasons. And one was that, first of all, it wasn't uncommon for doctors to start prescribing hormones to women in their 60s and even in their 70s at the time. So it maybe wasn't as strange then as it seems to us now. But the main point was that they were trying to study endpoints such as stroke, heart disease, cancer, and women don't tend to get that in their 50s. So but they didn't want the trial to go on for decades and decades. So they needed to start with people who were older to see what happened when they got to the ages when these risks really started to be more likely, to see if they could measure were there women having strokes? Were there women having heart attacks? What was
Right.
the increased risk? Doesn't happen, thank goodness, knock on wood, to most women in their 50s.
There were other flaws, though, too. The formulations of the hormones were kind of off. Now we have better hormones that more mimic a woman's natural biology.
So it's not as though the hormones were flawed, and those poor hormones, conjugated estrogen and medroxyprogesterone acetate, which was a progestogen, received such a bad rap, a really, really bad rap, and we still use them. However, there was a really, the number of prescriptions that were being written for the combination dropped dramatically. And unfortunately, it gave rise to some very unsafe options, but it opened up the world of what we call bioidenticals, many of which are great because there are several FDA-approved wonderful bioidentical options. You can get them through any commercial pharmacy. But I think people were so worried about safety that they started going to physicians who would prescribe lotions and potions, as I say, compounded forms of hormones that made women believe that these were safer options, yet they weren't studied. Mm-hmm. So essentially, they were trading something that they thought was horrible for them because of what they looked at the data, they looked at the WHI results, going to what they perceived to be safer options. And there were safer bioidentical options, but you needed to discuss it with your physician.
Right. But also, what about synthetic hormones? Haven't they been vastly improved since this study?
Yes, and one has to realize all hormones are synthesized. Many of them are derived from plant products, but they are all synthesized. They are made in a lab. We don't pick them from a tree. But I think that one looks at something that's compounded and prepared by a compounding pharmacy as being safer than something that your doctor may write for you. For example, they think their compounded products or their pellets now, for example, are safer than a patch that your doctor may prescribe or an oral pill that your doctor may prescribe. So it needs to be individualized. It's a huge discussion, but there are other options. They seem to be safer, but again, it has to be individualized because for some women, there are advantages to being on conjugated estrogen, which was the estrogen that was actually studied in the WHI.
I know Premarin got a very bad rap
Horrible
back in
rap.
the day because it was derived from the urine from pregnant horses, and I think there were at least my friends who are animal lovers were really upset about how the horses were treated and all that. Is Premarin still around?
It's around, and it's interesting. If you look at the data in the WHI, the women who use Premarin only, there was a decrease in the incidence of breast cancer. So it's very interesting because women who are at high risk of breast cancer may consider Premarin as an option. It's not really off the table, and there is one formulation available. It's where it's paired with something called basidoxifene, and it was taken off the market because it needed to be repackaged, and it's now available in Europe and Canada, soon to be back in the United States. It's a wonderful option for someone particularly who may be at high risk of breast cancer because Premarin may confer a decreased risk, but the basidoxifene also may actually be protective of the breast. So we have to really individualize it. This is not one-size-fits-all medicine.
Dr. Brightman, you are such a smarty pants.
I know those
love
words
it.
are very big.
I know. You talked about synthetic hormones, and I think for maybe newbies, they might not understand what it means to have compounded hormones. Sure. So what's the difference?
So there are hormones that are not identical to what the body makes, and that's what was studied in the WHI. So everyone, of course, went running for the hills after the WHI, and all of a sudden there was an uptick of hormones that would fall under the category of being bioidentical. They are molecularly identical to what the body was making: estradiol and progesterone. And while the FDA had cleared oral types of estradiol, transdermal types of estradiol, vaginal rings that supplied estradiol, and progesterone, many people opted not to go for these FDA-derived products, but to have products produced, same hormones, by a compounding pharmacy, a pharmacist that would, mix their own estradiol, progesterone, And many doctors felt, well, they could manufacture options for a specific patient with a specific dose to meet their needs, which was, I think,
Personalized medicine,
personalized, but to me rather unfortunate because we always had those choices available in FDA quality controlled fashion.
Right.
You know,
And compounding pharmacies don't have the same oversight.
we don't have the quality control, and they don't have to adhere to the same standards. It's not to bash them at all, because there are certain situations in my practice where I will use compounding pharmacies because certain things just are not here in our country or available to patients, or certain patients may have adverse reactions to the things we have that are available to them. So, but women opted for things that weren't necessarily safer for them.
I think one of the bottom lines here is that HRT has small risks but a big reward. Is that a safe thing for me to say?
I feel so. I've always felt this way. And what's really interesting, in the United States Preventive Service Task Force would say, no, 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 we are not supposed to talk about hormones and the benefits they may have in terms of disease reduction and everything else. But I think we've come a long way. You know, it used to be hormones were strictly for night sweats and hot flashes, and they had to be really, really, really bad. But we know that they improve the quality of one's life greatly if in need, and they also may serve a role with disease prevention.
All right. Well, we got a lot of questions about HRT, hormone replacement therapy. One asks, can HRT be used if you have a family history of ovarian cancer?
So that's a great question. There is a tiny bit of data that there may be a minuscule increase in ovarian cancer in women who use menopausal hormone therapy, MHT, or hormone replacement therapy. Again, it really needs to be individualized. I think much more goes into counseling a woman with a family history of ovarian cancer, and there's certain things one can do to reduce risks and certain genetic testings that can be offered, but it would not mean that someone with that family history can't be on hormones.
But they would need to discuss it thoroughly with their doctor.
To discuss it. But if there were an increase, it would be minuscule.
What if you're at a high risk for breast cancer is another question. Is HRT absolutely out of the question?
No. And it depends, again, on family history, again, on genetic predispositions. One has to, again, look at the symptoms, and with appropriate counseling, it's a very individualized, personalized decision.
Should women take hormones if they're only experiencing slight symptoms?
Yes, I think so. They should be offered hormones, and it should be part of the discussion. And I find I'm backpedaling with my patients, like those who have said years ago, my symptoms aren't terrible, I'm cruising through this. I'm now revisiting it because many of their eyes have been opened by Susan's wonderful article. So I feel that if I don't discuss it with them, I need to discuss it again. So, again, it depends on the woman. And even if I have somebody with mild symptoms, of course I talk about it because I don't want them to leave my office and think, she didn't talk to me about this.
And also in your article, Susan, you talk about, like, what is significant.
Exactly.
Like, how do you measure if something is bothersome or not, right?
Especially one of the doctors I interviewed, Nanette Santoro, was telling me that sometimes she'll say to her patients, look, maybe what you're feeling is menopause, maybe it's not. She would say to them, well, you could try hormones. You don't have to marry them. You can date them. And if you don't see an improvement in your symptoms in 3 months, we'll take you off. If you do see an improvement, I think we can bet that it was estrogen deprivation and you may choose to stay on them. So she was sort of saying, every patient is going to weigh their own personal tolerance for risk with the benefits to their lifestyle of going on the hormones, but you don't actually know the benefits necessarily until you've tried them. So look, if you're sailing through and you're completely symptom-free, then maybe it's not something even to think about. But if you're wondering about it, there's very little harm in trying.
My mother-in-law is 86, and she said, I love my hormone replacement, and I'm so sorry I ever got off of them. And, I think she misses the benefit of, I think she's quite petite, and I'm sure she has some osteopenia or osteoporosis, which is one of the things you get when you no longer have estrogen pulsating through your body. And speaking of that, I had to ask a personal question because I was diagnosed with breast cancer, as Dr. Brightman knows, in June. And I have been on HRT, the patch, probably, 10 or 11 years maybe now. And I loved it. Didn't look great with bikinis, but that's okay. I'm kidding. I don't wear bikinis anymore. But, I couldn't help but wonder, as Carrie Bradshaw would say, did the patch result in my breast cancer?
I would say no, it didn't. And as one of my friends was told by her breast surgeon when my friend asked, why did I get breast cancer? She got breast cancer because she's a woman. And if we think about it, 1 in 8 women will get breast cancer during the course of their lifetime. And this, we're not talking about 1 in 8 women in their 30s, 40s, or 50s. But by the time we live our lives, average life expectancy for women now is about 81. 1 in 8 women will get breast cancer. And my feeling is that is why. And I think for many women, if appropriately counseled, the benefits outweigh any potential risk.
But now that I have gotten breast cancer, I can't go back on the patch, can I?
Not really, no. There are certain situations with appropriate counseling where women have resumed hormones, but they are few and far between. And I venture to say the majority of physicians, would say it's a hard no.
Let's move on to some other questions we got from our daily newsletter, Wake Up Call, shameless plug, sign up at katiecouric.com, and social media. Follow me on Instagram, Twitter, and everything else. We got a lot of questions, Susan, about hot flashes. And I thought we would just take a moment because I thought it was fascinating. You talked about this internal regulator we all have that causes hot flashes. Can you explain, doctor, even though you're not a doctor?
I can explain what doctors explained to me, which is that the hypothalamus regulates body temperature and is very rich in estrogen.
I'm not getting a hot flash. I'm taking my sweater off. It just happens to be hot in here.
It's appropriately enough. It's very so the hypothalamus is rich in estrogen receptors. It's also somehow connected to the reproductive system. But so if it regulates body temperature and suddenly it's not getting the estrogen that it used to, it starts to get a little bit wonky, and it overinterprets little cues internally about rises in core body temperature, really infinitesimal rises, and it responds. The body responds as if there was some kind of catastrophic oven, from within, and it sends, dilates all the blood vessels, and it sends, sweat rushing to the surface of the skin. And the surface of the skin, actually, the temperature there really does rise. But what's so interesting to me about hot flashes is that women feel as if they do have an oven within, but it's kind of almost like a phantom limb sensation. Like, obviously, your inner core is not suddenly steaming, there's very little change there. But that's where women really do experience that heat. So it's really a purely cognitive kind of
brain chemistry.
It's a brain phenomenon. It's a neural phenomenon.
Is it the same with night sweats? People are like, we really don't care what you had, Katie, but I relate a lot to this conversation. I don't think I had hot flashes, but I did have night sweats where I'd wake up, not bad, but, my pajamas would be kind of soaked.
It's the same mechanism of action, the lack of estrogen and the firing away of neurons in the hypothalamus.
Why do some people get night sweats and some people get hot flashes
and some people
get both?
Everybody's different. Some people have brain fog. Some people have joint and muscle aches. It's so variable. It really, really is.
That's why it's so important to be able to talk to your doctor.
Absolutely.
And to really be able to share your individual symptoms.
And I find the joint pain symptom maybe the most fascinating. Because
unbelievable.
When I was at NAMS, actually, at this North American Menopause Society conference, I spoke to one gynecologist who was clearly educated on top of it. Here she was at the conference, and she basically said she had no idea that joint pain was a symptom of menopause. And I know I have one friend who, when she went off of the pill and realized she was in menopause, was convinced she had an autoimmune disease because her joint pain was so bad, and was getting all kinds of tests. And, nobody said to her, oh, no, this is a common symptom of menopause.
It's hard. It really is hard to parse out what are some of the usual symptoms of aging and what is menopause related. Like, I feel like I'm very creaky, and I don't know whether it's because I'm 66 or because I stopped taking HRT and now I'm on aromatase inhibitors, which suppress my estrogen even more.
Right.
Sometimes I get up from a chair and I feel like I'm a 95-year-old woman because I'm walking. And it's really frustrating.
Well, It's all of the above. And people on aromatase inhibitors, it's a hypoestrogenic state. So all of a sudden they can have all sorts of arthritic-like symptoms because there you are halting whatever estrogen your body was trying to make from the residual male hormones that are turned into estrogens after menopause. It's causing them to come to an abrupt halt. But the joint pain, it's really significant, and I don't think we ever realized it.
And what's behind that?
Well, collagen changes. There's less ligament laxity. The other thing is estrogen has anti-inflammatory properties, and we really see an uptick in rheumatologic diseases, arthritis, and all sorts of skin-related phenomenon after menopause. And I don't think anyone ever thought about estrogen having an anti-inflammatory relationship. Estrogen changes everything. It can change the bacteria that's in our gut. There's some thought that that gut bacteria plays a role with inflammation also. It's all interrelated.
I mean, it's a super hormone. I just love estrogen because it also creates estrogen is also like a natural antidepressant. And we haven't talked about this, but a lot of women who go through menopause become depressed because of the decrease in estrogen, right?
Yes, absolutely. They do. And they don't realize it. They don't realize it. Their doctors don't realize it. It's one of the most upsetting things to me. New onset anxiety, new onset palpitations. Women will go to their physicians and talk about it. And no, people do not draw a correlation between those symptoms and menopause. And I'm not saying that hormones are first line for treating anxiety and depression, but if it's part of the whole picture, absolutely it's worth a try.
Did you talk to many women who were feeling depressed when they went through menopause, Susan?
Oh, yeah. And I do think it's also hard for women to separate out whether it is lack of sleep, because of course that has a real effect on your moods, or
they're getting older.
Well,
and
that's a
they're
big
kind
part of
bummed
it
out.
too. The loss of the ability, the loss of fertility. They equate the loss of their period with the loss of femininity. So it's so multifactorial.
I wanted to bring up something that's so important is that these symptoms are often worse in women of color. Perhaps some of it is access related, but some of the other issues could be sort of biologically related. Why do these symptoms sometimes affect women of color even more severely?
So we really actually don't know, but there really seem to be some racial disparities amongst, who tends to have more what we call vasomotor symptoms or VMS, night sweats, hot flashes. There are certain ethnic groups, for example, women who are Black definitely have been noted to have worse symptoms. Women who are Asian, fewer symptoms. And what's very concerning is we want to make sure people are getting the appropriate care, because now it seems like the worse the vasomotor symptoms, the greater the risk of cardiovascular disease. So women need to be offered some education about it, information, and the option to treat their symptoms, particularly because they may be at risk of what lies down the road.
We want to get in a couple more questions from women who wrote in who are dry as the Sahara, let's just say. What you were talking about, calcifying, this is pretty much happening to a lot of women. One says, I've experienced extreme dryness and have had to take a 3-year break from sex. What can I do
That's
now?
so upsetting. That's so upsetting. Like I have to tell you, I really try to be proactive with my patients. And once they stop menstruating, talk about, are you having this symptom, that symptom? And they're like, no. I said, just be aware now that with menopause, there can be an increase of vaginal dryness, itching, burning, painful sex. And so I try to start the conversation that way. I think women do not think about that as being a symptom of menopause. And the interesting thing is night sweats and hot flashes will get better for the majority of women in time. What gets worse are these symptoms of vaginal change. We call it GSM, genitourinary syndrome of menopause. And there's also increased risk of developing UTIs. We see many more women with UTIs. They don't know that it's related to estrogen. Many of their doctors don't realize it's related to estrogen. Many of their doctors will send them off to urologists and everything else. So the good news is this really is reversible. Mostly it's reversible. I think that the nice thing is we have many options and different ways in which we can treat our patients. So, whoever feels dry as a Sahara, we can make that better. That's the good news.
Well, let's talk about some of the ways you can do that, because there are obviously lubricants. We have a whole video that Mary, who is sitting here videotaping our conversation, did about that, because some, I think, lubricants are better than others, and you have to be concerned about anything you're putting in your body. But there are other things like suppositories. I saw something on Instagram, and I want to check on this, where a woman was talking about these suppositories, and she said they have hyaluronic acid.
Oh, hyaluronic acid.
I
yes,
never know how to
hyaluronic
say
acid.
that. Hyaluronic acid. That sounded, I mean, anything with acid and vagina sounded scary to me.
It's the same substance that we find in like beauty products. It's a skin
Right.
plumper.
No,
It helps
I
the
know.
skin retain, moisture and everything else. That's totally safe. It may sound scary, totally safe. There are vaginal suppositories, which, again, accessible without a prescription. Many of these products are really expensive, which is really heartbreaking.
There's also an est ring, an estrogen
Well, there's several.
ring.
So to me, the best way to treat GSM is really the vaginal estrogen products, which it's very upsetting because they carry a boxed warning that pertains to the WHI, and they are safe and their doses are extremely low. But as a rule of thumb, we talk to our patients about using non-hormonal products first, wink, wink, because I really think they're less effective, frankly. But many people are, again, still scared of hormones, and some do contain hyaluronic acid. There are gels, there are lotions, there are vaginal suppositories. Some of the products out there are expensive. And for many women, they do work. One of the best things is being sexually active, for women. And how much sex is enough sex? I don't know. I don't know if anyone knows. I don't know how one could study that. But women who remain sexually active, with any kind of sexual stimulation. It doesn't have to be partnered sex. There is blood flow to the urogenital tract, and those women, it will be noted that their tissues look more estrogenized. They're less likely to have what we call GSM.
So use it or lose it.
Well, sadly enough for some people, and some people are not symptomatic, but the majority of women will have some sort of symptoms, and they should be aware of what their options are. And then in the category of vaginal estrogen, there are vaginal suppositories, there are vaginal creams, there are vaginal tablets, there are vaginal rings, there's an oral medication. So there's something that's a non-estrogen called DHEA, which is converted into estrogen and testosterone in the urogenital tract. So again, it's a whole long discussion. And then there's dealing with the insurance companies once you've arrived at a choice that makes sense for an appropriate patient.
And many of these, as you said, are not covered
not
by
covered.
insurance.
It's so upsetting.
Do you think that's going to change at all?
Gosh, I hope so. But it's so hard as a clinician because at this point, I will walk my patients through the options. I have a little room in my office where I store everything, and I'll say, these are your options, but I'll be honest with you, unless you've tried A, B, and C, or A and B, it's going to be hard to get, X, Y, and Z covered. And it depends on the patient. Some patients are okay. Others really want to try or stick within their plan, and I get it.
Isn't there some kind of procedure, too, that it has a woman's name?
Mona Lisa. So
yeah, that woman.
There are.
Have you ever heard of this?
No, I've never heard
really?
of this.
Oh,
No.
CO2 lasers. So there are lasers that are FDA cleared. That does not mean FDA approved. There aren't large numbers showing their efficacy. The doctors who perform these procedures claim that they're very helpful. I actually don't perform them because I think that the results that I need to see in my patients I can safely achieve through the use of vaginal estrogen. And there really aren't very large population-based studies where they look at truly using a probe that's at the laser versus using what we call a sham or a control device that simulates a laser and comparing the two. There are some studies, but the numbers are small.
Speaking of a population study, can you all explain to our listeners why there has not been another big study about estrogen or hormone replacement since the WHI folded?
Well, there have been many observational studies
Exactly.
at large population studies. Should I explain the difference?
Yes.
Or-
Yeah.
So I think the easiest way to say it is with observational studies, they're looking at a population of people who have made different choices and then working backwards to see how that's worked out for them. Whereas with a randomized control trial, they're randomly assigning people to placebo or the actual experimental drug. And that way there's no risk of confounding factors like, people who are better educated, who are therefore more healthy, made a certain choice.
And Doesn't the
down
latter
road.
have a little more credibility?
Randomized control trials have more credibility than observational studies.
So why hasn't there been a randomized control trial?
It was $1 billion project. I mean, it was
Funding?
Funding. The answer is funding. And I think they felt that they got some answers from the WHI and that was enough to go on, basically. Do you think that's accurate?
Yeah, I do. And I think the observational studies, particularly of what we tend to gravitate towards now, are very reassuring. But I think it would be hard to recruit a population that's equally matched, case-controlled, placebo, versus treatment to see whether or not there's a difference. My guess is many of the women want to use the medication, but I think it's getting the numbers and getting the funding to run such a large trial.
The problem also is that women in their 50s who are often very symptomatic, it's pretty easy to know if you're in the control group or the experimental group, because if you feel better, you know you're in the experimental group because this stuff really works. So again, it's probably one of the reasons they didn't use women in their 50s also in the original trial. And it would be a challenge to deal with that. Again,
I don't want to give short shrift to perimenopause because we really haven't mentioned that at all. Becky, is there something that you can talk about when it comes to perimenopause that will help women who may be in that phase of life?
When we talk about menopausal symptoms, these are largely the symptoms women start experiencing during perimenopause. Menopause is a transition, and there are different stages of going through this transition. But what we describe as perimenopause can last like up to 7 years, and many women can have regular menstrual periods. But the first thing they may notice might be getting warm at night. Then they may notice that they're, just not sleeping well. And, these symptoms can then snowball into heavier periods, irregular periods, moodiness, just a whole constellation of symptoms. Palpitations, which we haven't talked about. Many women are seeking out, cardiologists. And they need to be evaluated for palpitations, but that's also a symptom. So they're frequently symptomatic of other things that are frequently brushed off. And they tend to have symptoms that are what we describe as some of these menopausal symptoms. Some women during perimenopause have vaginal dryness. So again, it's very varied. People's experiences are very varied at the time.
When should women start talking to their doctors about this? Is there obviously every woman is different, but
every woman's different. I start now that I have a large menopause practice, I would say as women get into their 40s, I do. Early 40s, certainly mid 40s. And I think the hardest thing for my patients is when they're on the earlier side. It's sort of like, okay, who got their period, and for the women who are waiting to get their period. It's with menopause, no one wants to be the first one to go through it. Whereas I have other patients who are 56, but for the 44-year-old, the 45-year-old, where things are starting to change, and for some women they're younger, it's hard to discuss and acknowledge the fact that some of the things they are experiencing may be linked to the menopausal transition. So I discuss it in one's 40s and when I think it's appropriate.
I was just going to add that I think a lot of women are under the impression that you start menopausal hormone therapy when you are officially menopausal, which is to say a year after your last period. And they think that there's nothing they can do during perimenopause. Oh, I'm still getting my period, so I'm not going to get treated. But in fact, for women who are experiencing heavy bleeding or who are going through, their periods are irregular, they know that they're in perimenopause, they're having brain fog, they're having night flashes, there are treatments that they can consider as well, which I will now defer to Dr. Brightman to discuss.
Right,
right. You don't have to wait.
For example, the birth control pill can be very helpful.
Exactly.
What else?
So it's interesting because we have many things we can do after menopause, and the issue is you can't necessarily put younger women on these therapies because they will probably menstruate around them and have all sorts of bleeding that then needs to be evaluated. But if one is a candidate for birth control pills, low-dose birth control pills are a beautiful thing. They can use them continuously without even taking a break.
They just kind of even out your estrogen?
It creates hormonal neutrality. For many women, it just helps them sleep. They just feel better, and it's a great way to transition them through menopause. And I'll keep them on, depending on any underlying medical things. Medical factors, I'll keep them on birth control pills until, the early 50s or sometimes even mid-50s. It really depends. But many women who have a hormonal IUD, we can layer on a little estrogen through a patch, it works really, really nicely. The other thing is there are some non-hormonal options. Again, not everybody's a candidate for hormones. Not everyone can be on hormones. So Unfortunately, we only have one FDA-approved option, paroxetine, in our country right now. The FDA is on the brink of approving another medication called fezolinetant. It also it targets the hypothalamic what we call the thermoregulatory center of the brain. So that offers tremendous promise. It's non-hormonal. It will be great for women who are not candidates for hormones or who choose not to go on hormones. The good news is there's several other medications we can use off-label, some antidepressants, anti-anxiety medications.
And paroxetine is an SSRI.
Paroxetine is an SSRI, but
which
in its
is
lowest
a
dose.
Serotonin. Wait.
Reuptake, SSRI, serotonin reuptake inhibitor. That's
Yeah,
what
what's
it
the
is.
second S
yeah,
for?
Probably synaptic. I don't know. I would say SS because it's a serotonin synaptic. Yeah,
So,
SSRIs.
which are often used as antidepressants,
And
right?
for anti-anxiety.
If somebody's already on an antidepressant, then perhaps that can be changed to be an antidepressant that's been shown to be a little bit more effective in terms of treating vasomotor symptoms. And there are a handful of things we can do that are non-hormonal. And then the other thing is, women are very impressionable. We've talked about this. And there are non-hormonal nutritional supplements that many women opt to use. But the studies that are out there are very small. Many of them are self-funded by the companies that manufacture them. So if a woman is going to take a supplement, they should discuss it with their healthcare provider.
Speaking of that, there is a whole new group of companies that are addressing these symptoms with creams and vibrators and lubricants and all kinds of things, which I think is a welcome addition to the marketplace. But I know, Becky, you're of the school of buyer beware.
Buyer beware, and I think much the way it is for adolescent women, women should not get the wrong impression that they're being left out. Everyone's swinging from the chandeliers and, the women are missing out and they need to buy these products. Just because somebody has come up with a concept for a product doesn't mean one needs to necessarily buy it. That's on one hand. But the other hand, it's really nice to be able to embrace the fact that, I'm a sexual being. I want to remain a sexual being. And there are products that are out there that are really geared towards me, not towards a younger woman. So I actually think it's fantastic.
On the other hand, do you have to be careful about some of the claims that these companies are making?
Potentially, yes. I mean, you want to know what you're using, what is in a product like a lubricant or a moisturizer with certain, sexual aids. You want to make sure it's appropriate for you, if you have questions.
And, obviously there are all the supplements that are on the market too. Is, not just, I don't know if you're talking about like facial creams and misters and that kind of thing, but also supplements, which are, I don't know how dangerous they are, but they're certainly not regulated to the
Well, they're
degree.
not the nutritional supplements, which I was talking
I
about.
see.
Yeah. No, they're not. People need to know that. That's a great point. The nutritional supplements, they're nutritional supplements. They don't need to be cleared by the FDA, or they don't have to be approved by the FDA. Some of them are cleared by the FDA. But again, we don't necessarily have that quality control because the FDA doesn't need to weigh in on them. And while there are studies, these typically are self-funded studies funded by the companies that make these supplements. So again, buyer beware. For many of these supplements, there is a large placebo effect. And, quite honestly, if it works for you, even if it's a placebo effect, that's great.
But I know you're worried about all the stuff on social media, on TikTok, on Instagram, with these companies kind of overstating what some of these things can do and taking advantage of women's suffering.
Oh, it breaks my heart. It breaks my heart. I have a group of friends, fellow docs from North American Menopause Society, and they send around bad TikToks. There's misinformation out there. It's so upsetting. I think I would love to dispel some of the myths. It would be a full-time job. So it breaks my heart because we don't have great access to healthcare providers who are well-versed in menopausal medicine. So women are turning to social media, and there's some great things on social media, but there's some things that are potentially very detrimental.
In conclusion, I think some of the things I've learned in this conversation and through reading your great article, Susan, and through my conversations with Becky Brightman, is that a lot of doctors are not particularly knowledgeable about this. They don't have time, or they're uncomfortable. A lot of medical students don't really learn about this in med school. There hasn't been a really scientifically run definitive study about this since the WHI was shut down. And this is something that has been kind of ignored by large swaths of the medical establishment, which makes me wonder, is this indicative of how women's health issues have been treated historically?
Absolutely. Certain in the past, with respect to medicine, women were small men. Certainly, when I was in medical school, no one differentiated cardiac disease in women as being any different than cardiac disease in men, and we've learned so much. But now, the NIH has designated money that will go into researching women's health care. But this is all recent, and I think we do need more studies. And again, we have observational studies. There are certain things that I feel very comfortable doing for my patients, but there is so much more research that needs to be done. And education of physicians needs to be accelerated on a grand scale.
Susan, didn't they just start using women in clinical trials like in the 70s or something? I mean, when was the first clinical trial involving females? Do either of you know?
I don't know the exact decade, but I do know that women were excluded from many clinical trials for the very reason that there was the fear that their hormones were going to confound the results.
Those damn hormones, they screw us so many ways. So what do you think? I mean, what did you learn, Susan, about how did you feel about women's health and the attention paid to it after reporting out this article?
I think I would just quote Rebecca Thurston, who's a menopausal researcher out of the University of Pittsburgh, whom I interviewed for the piece. She's thought about this for many more years than I have, and her basic conclusion about the lack of treatment for women suffering from menopausal symptoms all these years is just a reflection of what a high tolerance we have as a population for women suffering. And it was a really grim assessment, but it's very hard to argue with it.
Well, hopefully things will change thanks to articles like yours and conversations like this. Dr. Becky Brightman and Susan Dominus, thank you so much. This was great.
Thank you so much, Katie.
Thank you for having me on. It's been wonderful.